A case of successful IVF outcome in a young female with infertility due to polycystic ovarian disease. A 28-years-old female, Gravida 0, came to the infertility clinic for evaluation. She was married for more than 5 years, but was not able to conceive despite not using contraceptive pills or any other form of contraception. Her husband was of about 30 years of age, and had no remarkable health problems. The patient gave history of oligomenorrhea and irregular menses, with spotting during the menses. Nonetheless, there was an absence of menses for the last 4 months. On evaluation, the patient was found to be overweight. She was 152 centimeters in height and 66 kilogram in weight, with a body mass index of 28.6. On physical examination, it was noticed that she had excessive growth of body hair on few sites, and hyperpigmentation over neck was also noticed. There was no remarkable abdominal or pelvic pain, and no tenderness on abdominal examination was elicited. Rest of the systemic examination was normal. However, vaginal spotting was observed on speculum examination. An ultrasound of the patient was conducted, which showed findings consistent with polycystic ovaries. Both left and right ovaries contained multiple small follicles, each side 10 to 14 follicles, measuring up to 5 millimeters. Laboratory investigations of the patient indicated that lipid profile, complete blood count, and liver and thyroid function tests were within normal limits. Fasting plasma glucose level was normal, but impaired glucose tolerance was revealed. Husband's semen count and other investigations were normal. Based on history, examination, and laboratory and imaging findings, she was diagnosed to have infertility due to polycystic ovarian syndrome. The couple was counseled about the diagnosis and its prognosis, and possible therapeutic options. She decided to attempt artificial insemination, and hence intrauterine insemination was planned to help her conceive. She received 2 cycles of clomiphene citrate and 1 cycle of ovulation induction and artificial insemination, but pregnancy could not be achieved. Thereafter, the couple decided to go for in vitro fertilization. Prior to IVF, her basal antral follicle count and basal follicle stimulating hormone levels were measured, based on which she was identified as expected normal responder. Within the IVF protocol, it was decided to perform controlled ovarian stimulation with recombinant FSH plus recombinant LH. She received a starting dose of 150 international units of recombinant FSH plus 75 international units of recombinant LH in a 2:1 ratio. On day 6-7 of ovarian stimulation, the dose of gonadotropin was adapted according to ovarian response, maintaining a recombinant FSH and LH ratio of 2:1. The medications were administered within a short protocol with gonadotropin-releasing hormone antagonist. The GnRH antagonist cetrorelix was started at a subcutaneous dose of 0.25 mg per day according to a flexible schedule, when at least 1 follicle with diameter of 14 mm or more was observed on ultrasound. Controlled ovarian stimulation was monitored by serial transvaginal ultrasound plus serum estradiol measurements performed every second day from stimulation day 6-7. From stimulation day 6-7 onwards, controlled ovarian stimulation continued until at least 1 dominant follicle reached 18 mm diameter, with appropriate estradiol levels. At this point, ovulation was triggered by injecting 10,000 international units of human chorionic gonadotropin subcutaneously, and transvaginal ultrasound-guided oocyte aspiration was performed approximately 36 to 37 hours later under local anesthesia. Classical IVF was performed, and after 2 days of in vitro culture, embryos were scored. Subsequently, 3 embryos were transferred in utero using a soft catheter under ultrasound guidance, and surplus good scoring embryos, 5 in number, were frozen and kept in liquid nitrogen for further use. The luteal phase was supported by administering 180 mg per day of natural progesterone for 15 days. Later, pregnancy was assessed by serum HCG after 15 days from embryo transfer, and then confirmed after 2 further weeks by visualizing 1 gestational sac on transvaginal ultrasound. Finally, successful pregnancy was achieved. The clinical outcome suggested possible benefit of using recombinant FSH plus recombinant LH in IVF in increasing the probability of pregnancy. Subsequent pregnancy course was uneventful, and she delivered a healthy girl child at 38 weeks of gestation by normal vaginal delivery.